Good morning again. It's my pleasure to introduce our grand round speaker, Dr. Hamid Mojibian. He's an associate professor of cardiovascular interventional radiology from the Department of Radiology, Division of Biomedical Imaging and Cardiology at Yale School of Medicine in New Haven, Connecticut. Dr. Mojibian completed his radiology residency and then vascular interventional radiology at Yale. Subsequently, he had a cardiac imaging fellowship at Texas Heart Institute. After returning to Yale as the section chief for cardiac imaging, he introduced mechanical thrombectomy technology for treating venous thromboembolic disease at Yale, and his division at Yale was the first to routinely offer such a service in the Northeast, and they've been one of the busiest centers to conduct these procedures in the past few years. Dr. Mojibian's main expertise is treating peripheral vascular disease, deep vein disease, pulmonary embolism, and dialysis access. He's been working on developing and improving imaging technology to help with interventional procedures or replace invasive diagnostic procedures. His recent focus has been using artificial intelligence to improve detection of PE and use of ECMO for massive PE. Apart from his academic achievements, Dr. Mojibian's by far most important achievement is marrying someone from the Topchi family. He is married to my cousin, and they live with their two beautiful daughters in New Haven, Connecticut. Dr. Mojibian, thank you so much for giving us this lecture. I'll hand it over to you.
Thank you so much for invitation. And Dr. Zechopchi is absolutely right. That was my biggest achievement, marrying his cousin. I always wanted to visit your place. I heard a lot about your adventures, ED experience there, and I wanted to see it by myself, but unfortunately this COVID does not allow us to travel. I had to stay home if I come back for 2 weeks. Wouldn't be a bad thing, but then probably my chairman wouldn't like it. I have not much of the financial disclosure. Always I say I'm not a cardiologist to have a disclosure, but I'm a local PI for CLOUT study from Minari that we are going to discuss their device. And the thing I just want to start with is that virtually we have no outcome data. All of these things that we are talking about is from the observational studies. We had a very nice review of the PE. I'm trying to go fast through the thing that you already talked about. We know that pulmonary embolism is the third cause of cardiovascular death in the US, at least 100,000 deaths, more closer to 300. The COVID hasn't got there yet. I know that we had a very, very bad experience with COVID. COVID is now in the US in the 250,000, but PE kills up to 300,000, and then there's not much of the attention to it. And interestingly, is the number one cause of preventable death in the hospital in the US. Then even the patients who recover, they may develop pulmonary hypertension, and those patients cost billions of dollars to our health system to manage. This is not that a benign procedure, but not always is like that. Many of the PI say is an imaging diagnosis now. If you are in the ED as an ED radiologist, how many PA study we get and how many we see is kind of, we see a lot, but many of them are incidental, or many of them have nothing really significant, or a small patient come with a chest pain or shortness of breath, but not really more than that. And the main thing is that the risk stratification of the PE is based on the RV function and patient clinical presentation, not clot burden. I'm sure many of you heard of the Miller index, that in like the 90s and 2000, people were talking about the quantifying the clot based on the Miller index, but there was no real association between amount of the direct association or linear that amount of the clot. A small amount of clot may cause a lot of symptoms, and a large amount of clot in the healthy patient may not cause much of the problem. Is as they say, all the roads end to the Rhone, all the roads into the RV, right ventricle, as you show it. Is the main thing is that how much of the pressure the RV can tolerate. And if you increase the afterload of the RV, it start dilating and start having some inflammatory changes, and the O2 demand goes up and ischemia. You can see in this picture that is RV is got big, and we compare it to the left ventricle. Then we always now ask our radiologists who read the study in the ED or in a chest radiologist that they mention the RV-LV ratio, because we think that it has a significant prognostic value as it goes more than 0.9. Anyway, as the RV pressure goes up, then this becomes ischemic, the contractility decreases, the output decreases, and then is the LV preload decreases. And this study, you can see that the RV is big, right? In this view, you should see the left atrium. The people don't pay much of attention, but actually in an acute PE, if you look at the CT, you can, and there are severe PE, the left atrium is really collapses. That's a study we are trying to do. There's one chest paper shows that patients who have the small left atrium have worse prognosis. People have just been ignoring it, but this is the area that patients started to accelerate everything. And then the systemic blood pressure drops, and then it became worse and worse, and patient go to cardiogenic shock and death. Again, this is the picture. It has a lot of value for us with the RV-LV ratio, and also personally, I look at the left atrium. Then the risk certification, we go based on the RV. Everything is about RV. If patient comes with a shock, is at the high risk or massive PE, and if patient is shocked, we put it automatically in the high risk category or massive. And the shock means that 15 is not that when you see the patient, maybe by depressor, maybe by supportive care, patient already recovered from that shock. But I'm talking about the 15 minutes of the sustained hypotension that we consider it significant. Then if patient is not in the shock, right, then we look at the RV. If the right ventricle is normal, and there is no biomarker that may be BNP or troponin, this patient falls in the low risk category with the less than 1% mortality. The problem is here, but the patients that they have either or both of the RV enlargement dysfunction, and also they have sign of the cardiac ischemia biomarker. If patient has either one, that means either the RV is big, with the ratio of the RV-LV ratio of more than 0.9, or as a cardiac biomarker, then patient is intermediate low. If they have both, then they have an intermediate high risk. And that patient, there's a wide range of mortality of 3 to 20% for those patients. And again, I'm just keep saying that it's all about the RV, right? And that's the thing, when I get the CT, I pay attention to more than anything else, rather than more than how much of clot you have. Then 70% of the cases are low risk. There is no hemodynamic compromise, no RV dysfunction, no myocardial necrosis, and mortality is less than 1%. Submassive, about 25% of cases, mortality of 3 to 20%, and massive and high risk, about 5% of the cases, and with the sustained hypotension, and patient may need an inotropic treatment, and then those patients have a mortality of 30 to 70%. We know the anticoagulation works, right? But when we want to go beyond the anticoagulation, and why we want to go beyond the anticoagulation, because we want to decrease the risk of death in those high risk and intermediate high risk patients, and also decrease the risk of possibly long-term adverse sequelae like chronic PE, pulmonary hypertension, and like the exercise capacity and quality of the life. Who gets it? Massive PE patients get it. You give a TPA, right? They do the intervention. Submassive, intermediate risk, those with cardiopulmonary deterioration, anticoagulation, we have not much of doubt to do it. Immediately for high, intermediate high is questionable, and immediately for all is questionable. This is our management algorithm. We assess the severity. We have a PER team, P response team, that any patient with the P, pulmonologist, echocardiographer, and the radiologist and interventional radiologist, they evaluate the patient. And then if it's a low risk patient, get anticoagulation and they can go home even if there is a low risk and treat as an outpatient. High risk patient, they go to ICU and the intervention considered for them. For intermediate risk, they go either to floor or intensive care unit, and they, if they have a lack of improvement or severe distress or clot in transit, or severe persistent orbital strain and sign of low cardiac output, and have a low breathing risk and good life expectancy, we consider to intervention for them. The P intervention is kind of, what is the goal? What is the goal of in the P intervention? When I'm talking about the P intervention, I'm talking about both pharmacological and both mechanical. It's not just the mechanical. We want to have a rapid relief of the pulmonary artery obstruction to increase pulmonary and systemic flow and correct the ventilation perfusion mismatch. That's a problem, right? And then reduce the pulmonary arterial pressure, reduce the RV compromise, and improve oxygenation, and hopefully reduce residual clot in the long run. But it should be a balance, right? What is the downside of this intervention? The downside of intervention is bleeding, right? That's a problem that we always have to see. What is the risk of this patient mortality, long-term sequelae, versus the risk of the bleeding? We know that the probably historical VT treatments are not the answer. The historical treatment is been anticoagulation and then probably thrombolytics. Anticoagulation, it takes time to get there. If patient is really severely sick, it may take 24 hours to get to peak. And then we know that anticoagulation prevent further clot to form, but just getting rid of the clot acutely doesn't do much, right? And then you keep the patient, keep the anticoagulation, hopefully that works, then it prolongs the patient hospital stay, and then it prolongs the pressure on the RV. If patients really have a bad RV, it may not be really helpful for the patient. The thrombolytics, they are good. It shows that the massive PE work, but many patients, right, they cannot get thrombolytics. They are post-op, they have a trauma, they have a cancer, they have a brain met, right? They cannot get that. And then also they may cause bleeding. The bleeding is a problem, right? And also they will have to go to ICU, have to watch them. That costs a lot of money. Then there are multiple studies that shows the benefit of the immediate perfusion, either by lytics, the systemic, right? That there was a PITO trial, a MOPE trial, in the massive patient, it showed that it helps. And for the more, if you don't want to give a systemic, the local treatment through the catheter, either with the ultrasound assisted or just with the infusion, the Ultima, Seattle, and Optilase that try to show that those catheter-directed thrombolysis may help. Even like the last study was the Optilase that they had the 4 cohort of patients that they only got the 4 hours of the TPA, 2 hours, 4 hours, 6 hours of the TPA through the catheter with the ultrasound assisted lysis. They all did almost the same. But again, there is no outcome data. They all have a surrogate, and surrogate is the RV-LV ratio in 48 hours. Again, none of this study have the outcome data. But all of these things, all of this, either systemic or the catheter-directed lysis, right? They are associated with bleeding risk. And that's a reason that even the latest CHEST guideline still does not recommend that we treat these patients, except patients for the massive PE, that they either can be treated with the full dose 100 milligram TPA, or they can be treated with the half dose that is almost equally the same. And what is their position on the catheter-based thrombus removal for the treatment of the PE? They only say that patients that are at the high risk of bleeding and fail systemic thrombolysis or shock that is likely cause of death before systemic thrombolysis can take effect within hours, those are the patients that may be candidate for catheter-directed thrombolysis. They are not really recommending it for intermediate high or anybody at this time. And why they are not doing it, right? Because we don't have outcome data, and the studies that we had, the bleeding was a problem. Well, the treatment options, again, the systemic thrombolysis, catheter-directed therapy, either with the pharmacological infusion of the TPA or mechanical. And also, we have a surgical embolectomy with the support of the ECMO. But mechanical, theoretically, should be ideal because we potentially can have immediate symptom improvement. Because if you can get rid of the clot immediately, right? What's better than that, right? With surgery, you can do it, but surgery, first of all, there are not that many surgeons know how to do it or willing to do it, or there are not that many centers with the surgical backup to do that, and the mortality is high. Then if every hospital had a surgeon to be willing to do it, probably that, and with the low risk, that would be ideal, but this is not the reality. Then the best alternative to surgery is that if you can mechanically go and get rid of the clot, and that will give us immediate relief. It can be single session treatment, and it eliminates the need for thrombolytics or ICU stay, and can minimize the blood loss and avoid need for capital equipment if he doesn't need any machine or any equipment. Didn't happen in other area of the vascular care. I think when I was in medical school, like in mid-90s, right? For the MI, what we were doing, I was the IC intern in the CCU, and then I was hearing, we didn't have it there where I was practicing, but the patient get the TPA, right, for the MI or lytics. And now even in the COVID era, that some cardiologists didn't want to take the patient to the cath lab, right? They're told, why we don't give a TPA, right? That was a discussion I don't think was ethically right. When you ED physician are in the front line and they see patient, why our interventionists don't want to do intervene. Anyway, but the lytics are for the MI was lytics, and then we move toward mechanical restoration of the flow. And the cabbage was good, even was mechanical, or with the stents and balloon. And with the stroke is the same, right? We were giving the systemic thrombolysis. There was a high risk of the bleeding. And we keep repeating the studies until we show that the mechanical thrombectomy of the stroke is potentially better than just giving the systemic thrombolysis. And I think the venous thromboembolism is going to the same route that we studied with the systemic thrombolysis, but now there are studies coming out that shows that we probably can achieve treating both PE and DVT with very low risk of the complication with the mechanical way. And why has not happened up to here now? Because the clot in the PA and in the DVT is not like the small amount of clot in the stroke. In the stroke, you get the very teeny tiny clot, and then you get rid of it, you are fine. Or in the MI, you stented, you are fine. But in the PE and DVT is a large volume clot, and there is a coexistence of the both chronic and acute clot, not like the brain or the heart. And also there are multiple branches you have to go and get rid of the clots. And then devices should be large, and then there is a complication of the bleeding, thrombosis from the access site, and injury to the pulmonary arteries, desembolization to the pulmonary arteries. And again, they were not an easy solution up to this point. We've been using it, like if patient was coming to to us with the really compromised function, then we had our rudimentary ways to help the patient. Patient had the central PE, then sometimes we were just getting the pigtail catheter going to pulmonary artery, flipping it around, trying to fragment those pulmonary embolus and send it out, and at least remove a little bit of pressure. We had balloon dilation, wire disruption, basket. People came with the different things, but they were not really answer to the problem. Then the angiogen, I don't know how many of you heard of it, is a very commonly used in the arterial system and in the venous system. That is a kind of works based on the venturi effect, and then you go and with the, like the, almost at the water pick, then you go and then put the high pressure saline infusion, and then you suck it out. And then in the peripheral, it works well, but in the heart, the people notice in the pulmonary artery cause bradycardia, heart block, and renal insufficiency, hemoptysis, and death, and FDA asked not to use it anymore. We don't use it. There is an Aspiration catheter, again, not really great. Then the device came, penumbra, that probably some of you heard of it. The smaller catheters been used in brain for sucking the clot out of the brain. Again, this one, the people developed the 8 French and more recently 12 French, and it's suggested to use in the pulmonary artery. Is just go in, you try to separate the clot and then suck it out. And then we tried it. We did not have much of success. I know that there are people in New York that are really big advocate for it, but it did not actually become very widespread use because people were not getting the result they wanted. And there was a lot of blood loss with probably around at least 600 cc in every session that we were doing. Then there are other device came market, is called AngioVac, that is a 22 French suction catheter that you technically you connect the patient to the perfusion machine. Patient needs to be on the pump, right, cardiopulmonary pump, and then you suck all the blood out and filter it and give the blood back. Then this is really good for if you have a RA clot or you have a clot in the IVC. Those are really suck everything out. It's amazing how powerful this thing is. But again, it was a large catheter and is a very stiff catheter. Maneuvering it to the pulmonary artery, not the easy thing. We use it, this one, but mostly for the RA and for the IVC rather than the pulmonary artery, and it's not an easy device to use. Then there is a new device in the market that came about 3 years ago. We started using it 2 years ago. It's from a startup, actually. It was one of incubator companies that started in California and now we live in public, I think, in head of the COVID at March. By the way, they have this catheter, they developed this catheter that comes from 16 French to 24 French, and you go from the groin or IJ and go through the RA, RV, and then to the pulmonary artery, and you suck the clot out. And then if the clot doesn't come out easily, you can use this nitinol disc and go and disrupt the clot and then suck it out. We've been using this for 2 years. Result. See if I can run this. The problem, this is the clot that you get from that device. It's kind of is that the main thing is the clot are large, right? And then this is the only thing can be compared to this is a surgical thrombectomy. then you can see these are the amount of the clot you can get from this with this device from the pulmonary artery. There you get more acute clot that is blackish, and even some chronic clot that are more kind of whitish. And this is a syringe that you suck the clot out. Then there was a study, they did a study called FLAIR trial that included 106 patients with intermediate risk PE, and primary endpoint, again, they don't have an outcome data, right? Is RV/LV ratio at 48 hours, and then they see how many days patients stay in the ICU. And then they had a significant improvement in the patient RV/LV ratio, with the 40% of patients did not go to ICU. And then there was adverse event of 3.8%. One patient had hemorrhage because of the hemoptysis, because of the catheter manipulation. That the 3 patients had the deterioration during the procedure, but there was no intracranial hemorrhage. There was no access site major bleeding, and there was no cardiac or pulmonary injury, or there was no devastated death because of this thing. And compared to thrombolysis, the mechanical, you can see if you want to do thrombolysis, we assist the patient. It takes us about only 30 minutes to go and put the catheter, but patient go to ICU at least for a day. And again, you have to take the catheter out, and then you have to monitor the patient, because the catheter directed lysis not get rid of the catheter, all of it, just debulk it a little bit. And then the patient is staying in the hospital for a few days. But theoretically, with this device, you can, procedure is longer. When we started, the procedure taking 3 hours, now it takes about 90 minutes. And then now sometimes I don't send the patient to ICU. I still am not brave enough. I send the patient to a step down, and then in a few hours I set them the regular floor. But again, the short of a stay is much, much less. And that can, in the COVID time, I think is a very big factor. I'm going to show you a few cases. This is a 56-year-old patient that came in July. In May had COVID. Then you can see that patient had a saddle PE with almost occlusion of the right side. Then patient had the enlarged RV, had a McConnell sign, had the BMP, troponin up, and then at this point for 2 years we have not used TPA, right? But this patient's COVID, they are reading all of this thing that the COVID patient may benefit from the TPA, and we wanted to go more kind of get rid of the microemboli, a small emboli, and we said, okay, let's use a TPA instead of our norm of the catheter-directed thromboembolectomy. And then we went and put the ECOS, and we just infused it for 6 hours. That means this patient got only 12 milligram of TPA, and that's it. And we took the catheter out in 6 hours, and then 2 days after we took the catheter out, right? Then we noticed patient mental status change, and she got the huge bleed and ended up with the craniotomy. It was very unfortunate. Patient was young, but again, we learned that even COVID patients or suspected COVID patients, we have to treat them with the standard of the care we have, because we don't have any evidence to treat them differently at this time. But again, this shows that even a 12 milligram of TPA may cause you serious problem. This was our very first patient that we did it with the thrombectomy. It was, I think it was December 2018. And then it was the first week we had the device, and I'm on call, and then I have not used the device before. I asked the rep to come in. The patient was the father of one of our nurses, 75-year-old, status post hernia repair. Then I had bilateral PE with evidence of right heart strain. Troponin was elevated, and it was extensive pulmonary embolus, and echo also shows that patient had right heart strain with a pressure of possibly 50. You can see the large P, the feeding defect in the left side is almost the left pulmonary artery is occluded. Again, these are the more images, and you can clearly see the RV to LV ratio is almost 1.8 or something, and septal flattening, again, has all the indication, but just surgery. And then, so this is the perfect case we used our device on. We went and did the pulmonary angio. You can see the feeding defect. It's kind of, you see all the feeding defects in the pulmonary artery, and then is the here, and you can see all of this feeding defect. There was a little bit of perfusion. Pulmonary pressure was 42, 320. We did we went there. This is our catheter. We go from groin. We try to suck as much as we could. This is our post procedure. The pressure dropped to 28, 0, and 12. And this is the clot we got from the right side, and this is the clot we got from the left side. Heart rate on the table came down. It was amazing. That's the thing I noticed, that these patients with the PE, as you suck their clot out, if you are going to see a good result, the heart rate comes down. That's the very first thing you can notice there. Then at the end, he went out of the room on room air with no shortness of breath, and he was extremely short of the breath. And then remained stable, no dyspnea with the echo. The RV came back to normal, and patient discharged to home and DOAC on day 4 post-procedure. This is the other patient that it was at a surgery, and then patient was transferred from another institution, found to have massive pulmonary embolism at outside facility, had cardiac arrest while in the CT scanner. They intubated the patient, 8 minutes of CPR, and then they give a TPA in the ED, patient on 2 pressor, they send it to us. Then, and the echo show has the RV strain, and even the lactic were up. You can see almost the left side is completely occluded. Then for this patient, we knew this patient is sick, right? It was a massive PE. And then we didn't want to risk it. We said, okay, let's put the patient on the VA ECMO. And then the patient came to the IR. And under imaging guidance, we put the ECMO arterial side, venous side. And then this is my first image. Actually, I look at this for about 10 seconds. This does not move, right? The contrast just stuck there. There's no perfusion to the left lung, right? The contrast just stuck there and it's not moving at all. Then we go down the left side also, you can see large defect. There's almost no perfusion here. And then we go and then we do it. And this is after one pass, we see that we restore the flow. There's some perfusion to the left lung, and the right lung completely perfusing, and you can see the clot that we got it from the right and left. And this patient is come now discharged, and then it's doing fine. It's amazing that how this patient recovered. But this device, as you see, it not only can be used in the pulmonary artery, also if patient comes with the SWC or IVC clot, or we started using this device. Like this patient we had with the very large liver cyst and then hematoma, then it was so severe that it caused a compression of the IVC and clotted IVC, you can see. And then nobody wanted to touch it because they were thinking if we are going to drain this, it's going to clot moves. Then we used the disc that comes with the device as our temporary filter. We went through the IJ, we put it above the hepatic vein, and then open it, use it as an IJ, and then as a protective device. And then we went down and we took the clot out. So you can see that everything is open, and we drain it and just we remove the catheter. The other application we have been trying to use it is for clot in transit. This is the case we did. We used a patient came with a large PE, and then it was a very small patient. Then patient had the clot in the RA and the PA. Then there was the patient was 89 years plus, and then we were able under echo just go and visualize the clot. We put our catheter and then we took the clot out. This is a clot. It looks very chronic. We took it from the RA, and then then we did a PE. We started using the transthoracic, but the other people are using the TE. We don't have access to TE for the clot in transit. Now we started using the ICE, intracardiac echo. That means we just go get 2 access, and then I use the ICE just to visualize the tip of the catheter and do the thrombectomy. The other thing that people don't realize, right? Use a TPA, use a heparin, it gets rid of the clot, but it takes a long time, and many times it does not get rid of the clot completely. And there are clinical studies coming out that the residual pulmonary vascular obstruction, RPVO, right, it may have adverse effect. And we want to clean out as much as we can, right? If you have a significant amount of RPVO, right, your mortality increases, right? And also you may have a chance of heart failure and dyspnea and the CTEPH in the future. I think that's important, that if we can get rid of the clot as much as we can, we get rid of the clot. But this device, this thromboembolectomy, is not perfect. The key thing is we go there and we try to get rid of the clot, but when I have to stop, because the first I started it, we were taking like 2 hours, 3 hours, we tried to clean everything. But really, there's a lot of radiation, blood loss. We don't know what is the endpoint. At this time, we just try to get rid of the clot as much as we can without really prolonging the procedure. If there's a chronic clot, it doesn't work that well. We are coming with the different tools to get rid of the chronic clot in this patient. There is associated blood loss. I had patients that I lost 600 cc of the blood, but now our blood loss is about 150, 200 cc. Then I always send the HNH, and I'm very have a low threshold to transfuse these patients if I think that if they're losing blood, because if they cannot tolerate the volume loss. If patient is long, there's definitely radiation you have to consider. We are, as a radiologist, we forget that we're radiating with the X-ray. You have if there is a complicated test, you make 30 minutes of fluoro time. That is a lot of radiation. Again, young patient with big breasts, particularly, you have to keep in mind that you don't want to radiate them. It's a large catheter. People are afraid to use it. You are afraid of injuring the tricuspid valve. Again, you have techniques to avoid that. Again, if you don't know how to use it, you may cause serious damage. It has a learning curve, and the most importantly, there is no outcome data. We don't have any outcome data for any of this intervention we do. In summary, there is no strong evidence for any interventional treatment beyond anticoagulation except in patients with catastrophic PE that may benefit from systemic thrombolysis, probably due to fact that the risk of bleeding offset the benefit value, right? And large bore mechanical thromboembolectomy is a promising method without the risk of bleeding. We may now turn around. If there is a study count that the patient is not bleeding, we may really now see a true benefit during the intervention compared to not doing the intervention. We definitely need more data. At the end, if you want to read one paper, I would recommend this one. I think it's a very good summary, very balanced summary. Many of the people you see are from New York. This is one paper I recommend if you want to read, summarize the interventional therapy current status of the intervention for PE. And that's it. Thank you so much. I will be happy to answer any question.
I just wanted to open up to anybody on Zoom or in person for any questions that you guys have.
Hi, Dr. Mojibian. I'm Angela. I'm one of the fourth years. Thank you for coming to speak with us. I'm wondering, what are the patient's anticoagulation needs after they get mechanical thrombectomy?
Actually, it's a very, very good question. The thing is that I'm general as a pre-procedure, right? The thing is that I don't know what you're using in your ED, but many of our ED started using Levanox for this patient in the ED, right? That it makes our life a little bit difficult if we are going to the thromboembolectomy, because we want to, during the procedure, keep their ACT above 200, closer to 50. And if you give them Levodox, it make it a little bit more difficult to really assess where the anticoagulation is. I like just the heparin before the procedure if it's possible. After procedure, is anticoagulation is exactly the same like for any other anticoagulation. Is kind of you keep them patient on the when they are in the hospital, we usually keep them on the Levodox or heparin, and then they switch to DOAC. And there is no no difference, the same anticoagulation, but no TPA anymore, no ICU stay. Just if your floor accept the patient with the heparin, they can go there, or Levodox. There's no different than any other, just a PE.
Thank you.
You're welcome.
There was a question in the chat. The question is, what can we do in the ED to help tee up the patient's mechanical thrombectomy other than stabilization? Are there specific nuances of stabilization decisions that we can make that can help these patients with respect to mechanics?
The way we are doing it is kind of, we really try avoid intubating this patient. They do much worse intubating, right? We try not to intubate those patients. Then if the main thing is we have to see if the patient is indicated for the procedure. And if you are okay with your point of care echo and you can document the RVS strain, that would be extremely helpful, right? We ask for official echo if you have time. If you don't have time, is a different thing. But if you have time, you want to get the official echo, if not your bedside echo. And the thing I want to look in the echo is not just the RVS strain, but also clot in transit. If it's a really clot in transit or not, right? That because it changed the way we are going to approach this patient. Then if knowing that patient has DVT or not, just looking at the groin would be helpful, then help with their access. And then stabilize the patient. If you are going to put down the pressure, it's fine, but you don't want to, we always say we don't want the patient die anywhere, but particularly in the IR, you don't have a way, or the cath lab or whoever is going to do it, is better that patient go stable. We have now brought down our threshold to put the patient on the ECMO, because we had a few patients that they came under pressure, and then we were thinking, oh, okay, they are stable, we can quickly do the thrombectomy. But by the time patient got to our room, they were become so unstable that we couldn't do anything more. Then we are having a rapid discussion with our pulmonologist, with our cardiac surgeon, that if they really have any suspicion, put the patient on ECMO, and we do the procedure. Again, ECMO has its own complication. We've seen so many complications from ECMO. I'm not advocating that everybody goes there, but the main thing is you have to have a very fast, open discussion. The PERT is the way to go. We found the PERT is really way to go. That have a discussion. I see a question: is thrombectomy feasible post TPA? Yes, it is. Then I prefer, if patient is dying, you do anything, right? If patient got the TPA and is not responding, then yes, if we just do it immediately. But if patient got the TPA and you are not happy with the result you got, you can wait for a couple of hours, then I think would be better. But if patient is going to die, then yes. And even with the thing we did it only once. I didn't do it. One of my colleagues did. Was a patient with a massive PE. They give the TPA during the procedure. They haven't done it, that they give 10 milligram of TPA during the procedure in the pulmonary artery directly, and then did fine even with that. We closed when we come out, we put this PERT string, and they've been doing fine. We haven't been there. We did around 120 cases so far, and we didn't have any major bleed on whatever anticoagulation. We definitely did a few patients after TPA.
Hi, Dr. Mojibian. Can I ask you a question about the case study that you reported for the COVID patient who had the intracranial hemorrhage 2 days later?
Right.
My understanding is the half-life of TPA is pretty quick. It's like just a couple of minutes. Is that common to see bleeding so many days later post TPA?
It's not. That's the thing. We don't know. We don't know what happened with that patient. The patient, actually, the thing is they go back and patient had some kind of slight change of mental status after the procedure, and they keep them on the full dose heparin, right? And then we keep them on the heparin. But that's strange. It's because of the COVID or because of the patient underlying problem. We don't know. But that was very unfortunate that after 2 years, we did one TPA, directed lysis, and that patient bled. But no, it's 6 minutes. And then that's the thing. 6 minutes is the half-life of the TPA, and we wait 6 times 6. That means 36 minutes. After 36 minutes, technically, TPA is gone. Even if I have a catheter in the patient and the TPA, after 40 minutes, I tell them, my residents, they can go and take the catheter out. But you are right. That's very unusual. We had multiple bleeding after the catheter-directed lysis. Actually, the report that it shows that there's not much of difference between the systemic TPA and the catheter-directed lysis bleeding after. But yes.
Any other questions?
I guess I have a question. We've been talking a lot about bleeding risk with like systemic thrombolysis. I guess the question is like, how do you risk stratify the bleeding risk and deciding who gets mechanical like thrombectomy? Because my understanding from the data shows like the PITHO is that usually patients are under 65. There's no increased bleeding risk. So I guess I was curious, like, what are you saying that people that are older are more beneficial?
Absolutely, very good question. I think that if you have your standard contraindications to TPA, right? If patient had this recent surgery, recent trauma, brain met, or you don't know patient has a brain met, or the hemorrhagic met anywhere, then the more patient more than 65-year-old, we get very nervous with the TPA. The older, that many of these patients we did actually they were older than 65, and then we know that the PE incidence is significantly increased in the 6 and 7 decades of life, right? That's a fact we know. And that those trials actually show that patients have bleeding risk. It's not that they're not increasing. They have a bleeding risk, but compared to 65-year-old, they have way less bleeding risk. But I personally seen with the systemic lysis, multiple patients that bled afterward. Also, but those patients, if you don't give it to them, also have a chance of 30% mortality, but compared to 2%, 1% risk of the bleeding is kind of, I think, is the risk we take. But definitely, patients get older, there's a higher risk of bleed. And we converted now, except patient come with a massive PE that they get the standard TPA, systemic TPA, we almost don't do any catheter-directed lysis anymore, except one case we did that I showed you in 2 years. At the beginning, we had some hesitation because procedures were longer. Not all of us were comfortable doing it, but then we went and taught each other. And then as we got more comfortable, we know our tools, how we know access, then we completely stopped using the catheter-directed thrombolysis.
I think we have any last questions, guys?
There is a question that are you finding with much utility in mechanical thrombectomy in those patients with hemodynamic compromise and stroke who are not candidate for thrombolytics due to time window? If patient, if your neurosurgeon can tell you that patient can get anticoagulation just during the procedure, I would do it. I'm saying if sometimes they say, okay, I'm okay, you give the heparin during the procedure, then not afterward, that's a different story, right? But then if they are okay, we give the patient anticoagulation during the procedure, we are fine. Without anticoagulation, without heparin during the procedure is not a safe thing to do because this catheter, as you said, is a large catheter, blood goes there, and the catheter forms a huge amount of clot. that may cause additional PE and patient's compromise. Yes, if our neurologist or neurosurgeon or stroke team say, okay, you can give the patient heparin during the procedure, at least we consider doing it, and we've done it.
Great. Okay. Now, I thought the parallel you made about the fields and cardiovascular stroke was very interesting. We appreciate you giving us this lecture. Any last questions or comments? Okay, thank you very much.